Hi, welcome. So our last speaker and our last keynote speaker is Daniele Fallin from the Department of Health at Johns Hopkins School of Public Health. She so happens to be my teacher when I was starting to learn about autism a couple of years ago as well. But much more beyond that, she's a world-leading expert in mental health issues, and she has been giving lots of talks and writing and trying to encourage the research community, science community to always keep mental health impacts in their minds and in their research agendas during the pandemic. So she will be talking us about how COVID-19 pandemic has been affecting our mental health.
Thanks. Such a pleasure. Thanks for the invitation and nice to see your face again. So as was just said, I chair the Department of Mental Health here at the Bloomberg School of Public Health at Johns Hopkins. And while my own personal research is on autism, I get the privilege of championing mental and behavioral health for populations through my role as chair. And so that's the lens in which I'm going to talk to you today. And this, rather than being, a very detailed and rigorous look at a particular, sorry for that. We, like many of you, are sharing home office space between my husband and myself, and that is his office phone that I can't turn off. Anyway, we, like many others, are noticing changes that we think are really important to address. And so unlike the previous talk that was very focused on a particular question and the methods and results that are around that question, I'm going to be hopefully ending and rounding up the talks you've heard today with a summary of sort of higher level principles and some data that's already emerging. And I want to, from the beginning, acknowledge my colleagues here at the Bloomberg School that really immediately said we need to be monitoring this mental health of our communities here and across the world.
Oh, Danny, I think we just lost your video.
So that collection of faculty, staff, and students has been amazing.
Danny, sorry, I think, I don't know if it's just me, but I lost your, you froze for me as you were just acknowledging your colleagues, but
oh no,
in their names. You were saying that you very quickly got together to.
Yes, from the very early in March, this group of faculty, staff, and students said, we need to measure this. We need to know what's happening right away. And I'll talk in this talk about why we think that's so important. And so they really took it upon themselves, despite all the other things going on in their lives, to do this well. And so they developed these measures and they reached out to many different groups to try to deploy these questions very early on. And so when we get to those parts of my talk, it's really through their work, Judy Bass, Liz Stewart, Johannes Thrull, Calliope Hulling, Renee Johnson, Luke Kalb, Kira Ream, Emily Smale, and Michael Friedman, that this has happened. So I think I might be speaking to a very knowledgeable audience about the importance of mental health as a public health challenge, but I think it's important to just lay this context and remind us all that mental and behavioral health were already critical concerns for the public's health. Depression and anxiety are extremely common. These are US numbers showing, the impact of diagnosable conditions like depression and anxiety, the consequences of suicide, which is a leading cause of death in the US and also across the world. The overdose death rates in the US have continued to climb. And even just feelings or symptoms of nervousness, anxiousness, et cetera, were already quite high pre-pandemic. That's not just true in the US, that's certainly true across the world. I love these kinds of pictures that show disability across the life course globally. And you can see these things in purple are neurological and mental health disorders, and the things in green are self-harm and violence. And so if you put those together, that's a critical amount of world disability that's due to things that I would characterize as mental and behavioral health conditions. So the reason I bring this up is that this is already a problem happening in our background, and we already know that there are severe consequences to having a mental or behavioral health disorder. Indeed, in most parts of the world, there is at least a 10-year life expectancy drop, some places as much as 25 years early death due to mental and behavioral health problems. Lots of co-occurring psychiatric and substance use conditions, lots of co-occurring physical conditions. For example, I often highlight what some may not realize, that there's really not separation between physical and mental health. In fact, those with something like depression, that's this cute target slide on the right or figure on the right, those with depression are at increased risk of many physical conditions, type 2 diabetes, stroke, breast cancer, heart attack. Many of these, what we think of as non-communicable chronic diseases in the world, have higher risk among those with depression, and that's true for other mental health conditions as well. And the reverse, if you are someone who was more interested in solving problems of diabetes globally, it would be of interest to you to recognize that your prevention and treatment efforts can do a much better job if you first address the depression and anxiety symptoms in your patients or in your community and population. And so regardless of whether your primary interest comes from the mental health side or the physical health side, understanding their interchangeability and how intertwined they are can improve both. And then lastly, the reason I think it's important to just give you this context is the situation of mental and behavioral health is that these are folks who often throughout their lives experience additional discrimination, often social isolation, reduced opportunities for their own life achievement in terms of educational or employment opportunities, and stigmatization of all different kinds. In the US, our Surgeon General has made this, one of his main missions. He'll say things like, heart disease doesn't kill people, opioids don't kill people, stigma kills people. That we have solutions to many of these public health challenges, but they aren't implemented the way they should be because of stigma, both stigma that's self-induced, stigma about family, and stigma that creates barriers to policy change. This is also not a unique US problem. This is true around the world. WHO has recognized both the stigma challenges, and then here I want to highlight the discrimination challenges that have led to severe human rights violations for folks experiencing mental or behavioral health problems. That is critical when we think about that's already happening as we move into what are the consequences of the pandemic and what should we be doing. I think I've painted a pretty gruesome picture. So I want to say on the other side, these are already known to be treatable and even preventable outcomes. So this is not a lost case. The challenge we have, we certainly need to know more about causes and risk factors, et cetera. But the real challenge we have is communicating that these are treatable and preventable conditions, and then motivate us to put in place those treatment and prevention measures at communities and population levels. We talk a lot in our department about suicide prevention, and I give this as an example because there has been conversations about whether or not suicide attempts and completions are increasing as a consequence of the pandemic. And we have lots of tools at our in our toolbox to address prevention of suicide. We know that restricting means works. We know that if the main means of suicide, for example, in the US is firearms, if we restrict access to firearms, we reduce suicide. In other countries, access to poison is a major means of suicide. So if you restrict access to poisons, in the UK, several years ago, it was a particular pesticide that was available. So things like that can work. And in the context of this pandemic, that's a really critical tool that we do have at our disposal. I will say it takes a multi-sector approach, and that's true across many things, but I think suicide is a good way to highlight that we have to simultaneously fight stigma, which I've already mentioned, and then provide not only medical supports, not only psychological supports, but also social services supports. So you can't do one thing and expect all things to change. And then the other context I wanted to end with before jumping into the pandemic issues is that despite the high prevalence of many of these conditions already, and the fact that we know something about treatment and prevention, most people affected never get care. In the US, only about 40% of people who need care get care. And this shows you in this figure to the right, across different kinds of disorders, what that unmet need looks like. So many people with alcohol dependence are not getting care, many people with depression, et cetera. And this is, as you can imagine, much worse in low and middle income countries, and depends on all the things that I just mentioned. It's partly about stigma, both your own stigma and the societal stigma. It's also about funding for different kinds of services. And it's about political will to change policies or reimbursements in the US in terms of insurance. But this is not a US problem. This is also a global problem. I like this figure that came from WHO a while back because it shows you what capacity looks like in most parts of the world. In many parts of the world, there is essentially no psychiatrist, or maybe one psychiatrist for something like 100,000 people. And only 1% of the workforce in general has mental health training or deployment. Most of those are nurses, but there are an array of other different kinds of specialties. And this just addresses, again, while this is a major source of disability, as I argued at the beginning, we are not resourcing this challenge well, even though we know about tools that could work. So I bring that up to give you the context that this is already a major public health problem. It has lifelong consequences. And so the experiences that folks are having now, and I will talk about whether or not we're thinking through folks who already have a mental or behavioral disorder and how the pandemic is affecting them versus folks who will have a newly diagnosable disorder versus the general population who will just have an uptick in symptoms for a while, potentially before it drops back down. All of those not only affect the immediate, but can have lifelong consequences. But I've also given you this concept that things are treatable and often even preventable, but we meet this challenge of unmet need, and we meet the deep and enduring challenge of stigma. So when we think about the consequences of the pandemic, all of us, including probably all of you attending this conference, know that social isolation can exacerbate existing mental and behavioral health problems. We also know that uncertainty can exacerbate anxiety. So we already have situations in the context of the pandemic that characterize both things: social isolation because of the measures that many places have had to take in the context of the infection, and also uncertainty in that even now in many parts of the world, it's unclear what will come next. And so concern for increasing of these challenges is just extremely warranted. And I again, the saying in the US is you're preaching to the choir. It's a very Christian-oriented saying, but the idea is that I'm telling folks who already know some of these things how important this is. But I hope that that resonates for you. So I think it's important to think through some of the sources of concern or stress because they may help to think about interventions that are tailored in certain ways. There is increased fear and anxiety around the infection or the virus itself. So many people have fear of their own infection, illness, or even death, and those are very real concerns. Many folks have that same source of fear or discomfort thinking about family and friends. Many folks have expressed feelings of powerlessness, that these are the kinds of things that you don't have any locus of control over. There are also many people experiencing grief. There have been lots of lives lost. And that experience of grief, we all know, is a challenged one. It's particularly challenged in a setting of bereavement where you can't do some of your culturally traditional ways of recognizing or having closure. In other words, there are many places where there are not in-person funerals or where folks have not even been able to see their loved ones who have died. And then there's related issues around access to care. If I have a appendicitis and so I have an acute illness, I am less likely to go into a hospital right now because I'm concerned about the consequential infection or overwhelming a system, even though it's not COVID related. So those things are happening as well. And then there are, beside the virus kinds of concerns, these very specific concerns to the kinds of measures different countries have taken to combat the epidemic. And so most of you on this call have experienced some either closure or stay-at-home order or social distance measure in your own country or communities. Many have also experienced loss of income, and we know from lots of previous literature that loss of income or financial strain is a source of anxiety that often leads to higher suicide ideation and things like that in some cultures. Social isolation, grief, and here I don't mean grief in the loss of a person, but many are experiencing real grief in the loss of events or opportunities. So loss of a wedding that you had planned, or a graduation, or a trip. Those kinds of things are real grief for many people in their experience. I mentioned uncertainty. Discrimination, unfortunately, is sort of intersectional discrimination. I mentioned discrimination before in terms of people who have mental or behavioral health problems. But in the previous talk, you just heard about discrimination against a particular group, in that case, Asians, based on all kinds of things, including some misattribution of blame for things around the infection. And so that is continuing to happen in the US and across the globe. Violence, sometimes frustration around the pandemic can bubble up in terms of violence. We've seen this with Ebola outbreaks. In the US, we're seeing a conflation of racial tension with pandemic tension. And then caregiving and parenting. Here in the US and probably across the world, the school closures and childcare closures, as well as the need to take care of your aging parents or grandparents, has created caregiving challenges that are unprecedented for most family experiences. Not for all, but for many. So I say this to give you this picture of, we had the context of what mental behavioral health looks like already, and now these very acute and severe precipitating emotions or other kinds of events. So when we juxtapose those, we have unmet needs that already exist that are getting worse in some places because of this, and we need to focus on intentional increasing of access. The stigma and discrimination I already mentioned may be heightened, and again, we need to focus on intentional combat of discrimination and stigma. And I haven't said it exactly like this before, but we already knew that inequity exists. There has already been a health disparity in mental and behavioral health in most parts of the world. That is further exacerbated by the current pandemic situation. We have seen it in the US in terms of illness and death affecting Black and Brown communities in the United States more than other communities. This is almost, I don't say entirely, but some of the evidence says that a lot of it has to do with both culture, but importantly, frontline workers who are not as privileged to be able to stay home in the context of these kinds of pandemic prevention efforts. So now what we're seeing is that in addition to the actual exposure challenges, all the things that I mentioned in terms of the mental and behavioral precipitating experiences would drive further separation of those with the privilege of having support systems in place, whether they be social supports, financial supports, or physical supports, than those who don't. We also see this in the US in the context of educational experiences. So I also want you to think through groups to consider. So what some of this research that I'm going to show you is trying to think through, do we have evidence of these things? The early hypotheses were to think through those experiencing particular economic hardship due to the pandemic, those who already are experiencing interpersonal or family violence now that folks are not experiencing the same surveillance system. So children are not in schools where things can be highlighted, for example, and folks are put into close quarters for very long amounts of time. Groups targeted for race or ethnicity reasons, and caregivers of people with physical and mental health. Again, I mentioned I do autism research. the caregivers of folks with severely disabled children are really experiencing a tough emotional wellness time right now for many reasons. And then there's folks that you guys can imagine are really critical. So many of you are doing work and thinking through frontline healthcare workers. I would encourage you to think through other kinds of frontline workers as well, including what we would call essential workers here. Those who are living alone or are isolated, and then in particular, vulnerable folks like children with developmental delays or other kinds of special needs who were used to very deep and frequent services who aren't able to get them. There's one other way that we have been talking about in our group to consider the effects of the pandemic on mental and behavioral health, and that is that the effects might be different by your starting point. So if you already are someone experiencing a mental or behavioral health disorder, you are at higher risk of exacerbation or relapse of the symptoms of your disorder. That's somewhat different than the context of someone who had not yet had a diagnosable anxiety disorder, but now may have first onset of a diagnosable disorder, perhaps in response to the pandemic, or perhaps just because it's that moment in time. But because it's that moment in time, those folks may be unfamiliar with psychiatric and psychological care systems, so they may not know how to seek that out as well. And they don't have the same sort of access to social or employer or educational resources to help point them in the right direction. So that's an added vulnerability for these kind of newly diagnosable folks. And then lastly, there's those who are already diagnosed, those who could be diagnosed, and then there's the general population who is clearly experiencing emotional distress and needs some kind of support or intervention, not because they have a diagnosable condition, but because they are experiencing things that can have these effects I talked about. So what do we know so far? So I'm just going to give you a couple of examples of evidence that indeed emotional distress is increasing. We have been looking longitudinally, although I don't have a great figure, that shows some evidence that this may be leveling off, but not in all groups. And in places where there is going to be sort of a new spike in the crisis situation, the pandemic, that may repeat itself. We also start to see particular groups that fit these hypotheses, those with financial concerns being most heavily hit with emotional distress. Early adulthood or emerging adults, which is interesting, underrepresented minorities, and other groups that do appear to be experiencing higher levels. As I will show you through some of these slides, these are early times. Getting and mounting research like this, getting it back, being able to vet it and analyze it rigorously when we're talking about something that just started really in earnest in March. We are now in July, so that's only about 3 months, and that's a very short time span to do this kind of work. I will then show you some preliminary work that suggests that distress is associated with media intake, and that highlights the importance of thinking through calibration of your own media intake. And then lastly, other kinds of distress related to very local issues. And I want to highlight that even in most countries, different communities have taken different measures and have different background contexts, and that matters. So here's one example of work being done at Hopkins, where they had access to a survey that they could deploy very quickly, so between April 7th and April 13th of 2020, and had similar information from 2018 on the same questions. So you could compare what it looked like in 2018 versus this window of time during the pandemic in 2020. And so what's on the left is a summary of the findings to highlight, but what's on the right is the actual data. And so I'll just show you that in general, at the very top, you can see that the dark color is the April 2020 information on distress, psychological distress, and the light gray is the 2018. So you can see a very dramatic increase in proportion of people reporting psychological distress. But if you break that down to look at who particularly is affected in the US, you see that everyone is. But in this group, you see that folks of Hispanic origin, according to this survey, were experiencing it at even higher levels than the other two identified groups. Women a little bit more than men. And this is the age thing that I mentioned to you. Remarkably, these emerging adults seem to have the most experience of emotional distress. And we should think through that, because there's a lot of hypothesis that it would be the much older folks who would be more isolated, more scared of their own risk of infection, et cetera. And what this shows is these financial consequences and some of the other this is a time when a lot of mental and behavioral health disorders start to emerge anyway, that this might be a vulnerable group that we should pay more attention to than we had hypothesized earlier on. And then financial burden, so those with the lowest income show the highest challenges. So these fit in some ways our hypotheses, but also go beyond what we would have known had this not been carried out. The Kaiser Family Foundation in the US has also deployed their own surveys, and they see similar things. This is from an earlier time. This is March, so a little bit earlier than the April data I just showed you. But again, in their 2 weeks span in March, they already saw an increase in the folks who were reporting negative health impacts due to the pandemic. And when they broke it down, they also saw that women more than men. They saw that Black and Hispanic more than white. And they didn't see a huge difference between those who were caregiving young children versus not. But again, this was early on. School closures and things like that had just started happening or not happened yet. So I mentioned the group that I was lauding at the beginning here at Hopkins, and they immediately went to work trying to design measures that could be deployed on survey panels, both in the US and across the globe. And so I'll show you on this slide. And the next one, this was a nice write-up about how they came together. And on the next slide, I'll give you the website where they have put all of these measures available to anyone. So all of you who are interested in using these can go and see the details of each one. And so far, they have put them into a Pew survey in the US, another survey called Understanding America that's run out of Southern California, one run out of Texas. They are working with groups that are running national and international surveys using the Facebook platform. Some of you on Facebook may have been asked to participate in these. It's touched, I think, millions of people across the globe at this point. And then also an autism specific one. So this is the website that I mentioned, where you can see, if you go to this link, and then you look at the research, you'll get opportunities to look very detailed at the different measures that were used. They really are highlighting adult mental health symptoms, including particular diagnosable outcomes, but also symptoms. There are some substance use questions there as well. What I think we need to do a better job of is getting child-based symptoms. And so we worked on child-based things for another project that doesn't yet have data for me to show you. But if that's helpful to you, please go there and check those out. They've been interested, and I say they, I'm part of this group, we've been interested in asking several initial questions. And so, the first is what's sort of the evolution of mental and behavioral health challenges amongst the 3 different groups that I mentioned, those already affected with a disorder, those who could be newly diagnosed, and the general population. Which individuals are at greatest risk, and how do behaviors such as media consumption affect this? So I'll jump to one of because I already showed you some of the evidence that emotional distress is already increasing. So I'll jump into this media one. And so this is a tough thing to ask with rigor, partly because many of the things that we deployed don't have prior to pandemic data on the same people. So doing it longitudinally really is at a point and then moving forward. That limits your causal interpretation of many things. But this Understanding America survey, in this case, you can see the dates. They're kind of small, but this was from March 10. In the US, we put the month before the day through the end of March. So for about the last half of March data. And what you can see is that social media consumption was going up. So was traditional media. So newspaper, mainstream news, those kinds of things, as opposed to social media kind of information. And while that was happening, distress as measured on the PHQ was going up. And so I show you this just because graphically, I think it's useful to see. This is among adults in the US. We also ran regression analyses, and that's what's in the paper that is now published in American Journal of Preventive Medicine, that you can see there is a modest association between time spent on social media or number of traditional media sources and these depressive symptoms rise. We can't say that that's a causal relationship, but it does at least suggest and reinforce the notion that monitoring media intake and sort of controlling or calibrating individual level media intake might be helpful. I also put this slide in from a different analysis of Understanding America that was looking at similar time points. So this is for a week's time in March. And this is showing by day across that week, the severity of PHQ levels. And what you can see is that they were generally going up. What we saw was this kind of pattern was most clear amongst the United States states that had the highest levels early on. So if you recall, at this moment in time in March, Washington State, New York State, a couple of places were very specifically hit, while many places in the US had not really been that affected at all. And so I highlight this to say that country level data would not have been as useful for us as looking at state or community specific level data. And that's important for all of us to recognize as we think through what are the strategies and the things that are most important in our local communities. And then there's less research oriented and more journalism oriented information. I put this in because I thought the Washington Post early on did a good job of summarizing some other hints at the concerns that we should all have in terms of capacity. And so if you see on this, they gathered information from like hotline use at our mental health and substance use federal organization and showed that 20,000 people in April were using their hotline compared to 1,800 the same month the year prior. Mental Health America, which is an advocacy foundation here, had huge increases in website access. And the number of people that were screened through one of their screening programs had sort of gone through the roof. And so I say this really to highlight capacity needs. That means you have to have enough helpline staff to be able to text or speak to people who are seeking help. You have to have, website capacity to be able to handle maybe 100% or a 300% increase in people trying to access your website to get information. You have to have people in place to be able to monitor screenings and deploy resources should people screen positive. Those kinds of things are real behind the scenes capacity issues. And then the last thing I want to say about this section is this is not a one-time, so I'm giving you data from March and then I gave you a snapshot of data from April. We know that this is an evolving issue. And we have some particularly global mental health history to rely on in terms of what we would expect the emotional trajectory to look like. And so here's one example that comes from our SAMHSA website that shows for a disaster kind of response, what might happen in terms of when the event first happens, when people start to feel like, oh, I feel empowered, I'm helping, I'm doing something in my community, to when the disillusionment starts and people start to feel hopeless, to a time when you start to move away from it and come back to quote normal levels. And many people are sort of operating on a model like this, which can be quite helpful. However, we know that there is no one trajectory in the around the globe right now for how the pandemic has not been a single event for many places. I show data from the UK. This is from the Hopkins Coronavirus Resource Center, which has been a source of counts since the beginning. And so this is just showing up until very recently, like yesterday, I think. And so you can see the shape of something like the UK, where we might start to think that this might be a single event and we could start to use a model somewhat like this, maybe. Here's an example from the US, though, that looks quite different, as you all know. So we are sort of entering yet another phase. And across the globe, we see a mixture of these kinds of experiences. And so not only is the timing itself different by place in the world, the shape and the trajectory of how people are going to experience it is different. And so that means we may want to think through new models. So we may want to borrow from Ebola, other SARS outbreaks, things like that, to think specifically not about a kind of earthquake crisis, but more like these prolonged, evolving, and dynamic crises that do start with anxiety and fear. And I put in green, we know that these can be mitigated by accurate and clear information. And I think we have a good example that in countries that were able to provide accurate and clear scientific communication early and often, their emotional distress and actual pandemic infection success has been better. Um, that initial period then is followed by this kind of what some call prolonged uncertainty. And this is where inequities start to come about. So folks who have either internal resilience or have better psychosocial supports around them or better financial supports around them tend to start to do better in this period of prolonged uncertainty. This is another place where the role of leadership and mental health care providers is important to provide clear and accurate information about access. Then there is this idea of a new normal, but this can last very long times. And this is where we really get concerned about depression-related symptoms, substance use problems, and then anger and aggression and violence experience. And that's where we need this substantial investment in screening, treatment, other kinds of supports. And then I put in red, all of that is assuming still a kind of dynamic but single event. As we have this recurrence of closures or crises in places, there may be a repeat of the above with even stronger effects. So when we think about longitudinal modeling of this, we have a lot of work still to do. The US has done lots to try to help, and many other countries have done lots in their own right that include really successful communication. In the US, one of the most important innovations has been the coverage by insurance of telemedicine, which wasn't always covered. So folks who need psychiatric care and can only get it via Zoom, for example, coverage was a problem, and also privacy violations were an issue. So things like Zoom are not secure. And so in real world times, that would be a problem for some folks to be allowed to deliver care via an unsecured web system. But we were able to circumvent many of those problems so that care can be deployed, and that was critical. Other kinds of financial supports for hospitals, community care, things like that early on have been very useful and important so that these things don't go under and a safety net remains. Provision of information so you can easily find help and you can easily find resources specific to your vulnerability. So if you are somebody who already has a substance use disorder, for example, or if you are someone caring for a child with disabilities, et cetera, there's help that's very specific to your needs. There have also been networks of volunteers, other kinds of what I would call lay or peer support networks that have been extremely important. And then lastly, workplace supports, like what we have in terms of employee assistance programs, are a great tool for deployment of these things. Okay, and then I'm just about over. I would say this is true in the global context as well. WHO and many other places are working to have these same kind of supports that are also culturally and language appropriate. We have a lot of work to do. We're still trying to struggle through understanding particular prevalence and incidence of symptoms and disorders, what those time trends look like, and who's most at risk so that we can target intervention and prevention appropriately. Monitoring changes in attitude and stigma so that we can address those, as I mentioned, are critical to really doing this well. Household functioning, so interpersonal violence, things like that, are really still not well understood, but we're such early days right now. And that highlights, as I mentioned before, understanding what's happening with children in particular has not been as easy to deploy as some of the adult panels have been in terms of community data. And then all the interventions that are being tried, because people are just trying things, evaluation of those and putting those into place for longer term use and not just stopping them when the perceived emergency is over. Having evidence base around the effectiveness of those is going to be critical. And so lastly, I'll leave you, I won't go through these one by one, but I'll leave you with, we're all individuals watching this. And while we're thinking about population mental health, we also are exercising individual care and modeling individual care. And so we and others have written different kinds of op-eds or tools that remind us of some tips. And so I found this one by one of our faculty members to be quite useful, very simple. We already talked about limit of intake of media, daily routines, truly still finding a way to find happiness and pleasure in your own experiences. It seems like a simple thing to do, but it can be hard and you must be intentional about it. And then a little bit of cognitive discipline, reality testing your own thought patterns. And if you start to spiral into something that is, sort of perpetuating negativity, we know, those of us who know cognitive behavioral training and other tools like that, know that you can really put yourself in check and try to reorganize your thoughts and check yourself when that starts to happen. And that those can be extremely useful at the individual level. So I just mentioned a couple of articles that our folks have put together to try to help in that way. And this is just highlighting to you those things. And then I would say communicating that. So that's at the individual level, but then using communication tools to deploy those tips at the population level are really critical. And so spending time and resources to do that is so important. And thinking about it through your audience. So I run a mental health task force for our Bloomberg School of Public Health. So our audience is students, faculty, staff, and potentially parents of our students at the university setting. If you are doing this for frontline healthcare workers, you have a different way of thinking. If you're doing it for patients, you have a different way of thinking, et cetera. But that communication strategy is key. If you are doing this globally, you have a different way of thinking. And so folks working on refugee responses have really thought through this a lot and are developing tools that are not something that you have to access the web and read in a translated language, but are very specific to needs and deployable in ways that are realistic. So summary, we have to continue with clear and accurate COVID communication, but at the same time, continue with mental health communications that are tailored to high-risk groups and that are combating stigma. We have to continue to advocate for increasing resources. We have to take a multi-sector approach to this, and I mentioned that a little bit. And then importantly, we've got to create infrastructure for long-term follow-up and monitoring. This is not a, we stopped doing COVID-related mental health research, come end of 2020. This is something that we need to pay attention to for many years to come, not only on the services side, but also on the research side. So I went a little bit over, I apologize, but thank you for inviting me. And in my world, I've had my own struggles with handling the pandemic. What has helped is we got a pandemic puppy. So this is my new puppy who is now 5 months old. It may sound cliche, but it really has made a difference for my 9 and 10-year-old sons who really needed that, that sense of purpose and unconditional love. So thank you.
Thank you very much, Dani. It was really nice and a perfect way to round up all the talks that we had across the 3 days. There's been some very interesting comments and questions for you on the live stream, and some of them are linking to all the many questions I had in mind as I was listening to your talk as well. So one of the ones that I think is a bit of a running theme is about the pandemic affecting our mental health negatively. So there's this question by Francis and followed up by Rachel. Can we not focus perhaps on the more resilient population who may be the majority rather than, the minority who've been very severely but negatively affected by it? He suggests that it might be important to understand them. And Rachel suggests that perhaps introverts might be the people who are particularly doing good during the lockdown, which reminds me of Sarah Cassidy's talk yesterday, where she was focusing on well-being in autistic populations and saying that perhaps there are some positives in there, in the sense that we started utilizing these mediums that for therapy and other get-togethers that just were not being picked up on by the general public before, but thanks to, of course, we can't say thanks, but in the context of the pandemic, suddenly they started to become our normal. What would you say about that?
Yeah, so thanks so much. That's a really great point. And so I went back to one of the slides that I had up, but didn't focus a lot of time on, and that was one of the key unanswered questions for us in the group here doing research is exactly this question of what's the role of resilience and what are pro-resilience factors at the individual, but also at the community and society levels. There are, quote, resilient communities, as well as you guys are pointing out, resilient features of the individual. And those are critical because those are ones that we can enhance or emulate at the community and society levels in terms of policy. So I absolutely agree with that. Johannes Thrull, who's in our department, right now is working on a resilience and pro-resilience paper based on the Understanding America data. And so I hope that we have better information around that soon, because you're absolutely right. And it would be really fun to have data around those to show, in addition to the kind of stark emotional distress stuff, which is where we are right now with the data.
Yeah.
The other thing to say is you're absolutely right, and that was you're absolutely right about the tools that are now being deployed with some success, and that's that top one in some sense, that is telemedicine being used, and is it effective? That could be in the autism world, for example, applied to how are some of the occupational therapy or other things that are now being deployed in ways that are reaching communities that usually didn't have access, or people who spent 2 hours on a bus just to get to a
Yeah.
facility, those kinds of things. So there are some important things that are good that are now becoming more normative. And so we need to build evidence around that. We need to be able to then go back to our service providers and our policymakers and say, this happened, and now we can show you that it actually is a good thing and we should fund it moving forward.
Yeah, yeah, absolutely. And there is also some interest in your to peer research on the child data, which I am very interested in as well as a child psychologist. Especially a child psychologist is working mostly on social support and bonding. So I think it was Merle who was saying that it would be very interesting to track whether they would be looking at the child's mental health as well as the carer's mental health and how these things interact.
Yeah, so I can tell you one of the studies that I lead here in Maryland is part of a 6-site United States study, and we are right now sending to the IRB our measures to be able to deploy questions to a group of about 1,000 autism children and their families, 1,000 developmentally delayed non-autism, and 1,000 population-based controls that were part of an autism study. But our questions in that COVID project are in 3 categories. So one is the kind of mental and behavioral health of the kids. And these are young kids. These are kids that are 3 to 5 years old right now that we've already assessed in the past year prior to the pandemic. And now we're going to go back and particularly look at behavioral issues for them. But then the second set of questions are around parent and caregiver health and mental health and stress. And then the last are around services utilization and disruption. And so what has been disrupted, what has been replaced in different ways, et cetera. And so hopefully that will get at some of those questions that you guys are bringing up.
Yeah, I will be looking forward to it very much. There's a lot of advocacy here in the UK, I imagine in other countries as well, similarly about paying more attention to young people. And I myself, I'm hoping to get some funding to do some research in adolescents in particular, seeing as, and your data speaking to the young adults was particularly interesting for me in that sense as well. Because again, as Mer mentions in the comments as well, there's this at least theoretical difference between different types of social support that we can receive from our family, which is the group of people we end up seeing very frequently these days, but that's not really the main source of social support for many adolescents, because peer-to-peer contact is really crucial during those ages. So it will be very interesting, I think, to see how children, young children and slightly older children who are young adults are being affected.
Yeah, I think that's so important, but I think we as researchers, which I assume many folks on this discussion have to think about the challenge of that. So what we've encountered is it was fairly easy to put these kinds of questions onto these survey panels that adults regularly fill out. And it's easy to recruit thousands or hundreds of thousands of adults to fill out a thing via the internet. It's harder to reach adolescents and really hard to reach children without it being a more established cohort kind of research study, right? So instead of a population-based survey, it now becomes these, selected and enrolled cohorts for many of what's being done. So it will be a different representation of the populations than these adult survey ones were. Probably even more important, but we'll have to think about how we interpret information that we get when it's more likely to be selected responses compared to the adult stuff. But you guys might have different opinions about that. That's just the kind of conversations we've been having. It turned out to be harder to do it for minors.
No, yeah, absolutely. My personal plan was to utilize this YouGov company, which has a large database of nationally representative samples from UK, US, Germany, many other countries as well. But yeah, nevertheless, it's definitely much harder to access children. Yeah.
One possible suggestion is some work that we're about to embark on is that, obviously with adults, you have the option of asynchronous data acquisition. You send out a survey link, but that with children, with minors, it might be preferable to actually have synchronous, so but still online, so still COVID safe studies where obviously you're not going to be dealing with the thousands of data sets, so you might have a smaller cohort, but the data quality might be higher, and actually the access will be obviously much higher. So that's something you could look into, either Baha or Danny.
Yeah, I do know in the US of some folks doing substance use work in the context of the pandemic with adolescents, but primarily qualitative and mixed methods with an emphasis on the qualitative part. So focus groups and interview to gather qualitative data about adolescent experience with substance use in this time. So you're right, there's also that kind of synchronous work, which is less quantitative, but really valuable.
Yeah, what we're doing is going to basically walk them through some implicit and explicit measures, quantitative measures, but online, so that you sort of, as if sitting side by side in a lab, but you have their parents next to them in case they need further instruction or they need to take a break. And so it is a lot more labor intensive, need a lot more man hours and a lot more funding to pay for those. But it is one way to sort of tackle that issue of accessing minors and being able to ensure that, they understand the questions you're asking. One of my follow-up questions was really that, for the adolescents, for example, it'd be very interesting to know the difference between the amount of support they think they're getting from their peers through social media probably, versus how much they think they're getting from their family. And whereas where my hypothesis would be that they're actually getting a lot of the physical support and mental support and emotional support from their family members, it's not necessarily recognized. I'd be really curious to look into that mismatch in expectations and recognition of where they should be turning to for help, especially at a time like this.
Yeah, I agree. And also timing like this. Like, I think one of the challenges is that same question, if you asked it in March, might be very different than if you ask it now in July, and different again if you ask it in November, given the evolution of these things. So it would be, you already said, like, it's hard to have enough funding to do this well, and then to say you need to do it 2 or 3 times. It's really tough. But I think it's critical.
Absolutely.
Yeah. Well, thank you so much, Danny, for your contribution. I think we will move on to wrapping up the conference now, and I'll hand it over to Merle. I think she has a few closing remarks that she'd like to make. Yeah, thank you so much. And
thanks for the invitation.
Thank you so much, Danny. We're so fortunate to end with you. It's a high note for certain. We have a lot of high notes, and that's basically all I want to share with you all as we come to a close on this, the 3rd day of our conference together. I hope to end on some positive notes, because in this, our last day, we've had a lot of people telling us how to move forward, whether it's by getting a dog, which I'm also looking into getting, because we already have a dog, a cat, and 4 kids. So why not add to the menagerie? You can never go wrong with a puppy, I think, is basically the best advice. And we had pictures from our keynote speaker, Frances McGlone, yesterday of rubbing and massaging cats and dogs and hedgehogs. So that was a nice positive note as well. But today we've had a lot of really useful ways of thinking about how to move forward, both as a research community, how we can translate what we're doing, communicate it effectively into really effective policy. We've heard about how we can buffer our own mental health, whether it's by buying puppies or mindfulness meditation. I think it's been a perfect way to close what has been a very productive, a very intense 3 days. And to sort of wrap up, I want to first hand over with a special note of thanks to Olga Lantukova, who's been in the background, keeping things ticking along. And she has a couple of words to say to also show how effective and productive we have been as a group. So Olga, we'd love to see you, and we'd love to see your screen.
Hello. I would like to share some of the best Twitter moments, because this event was on Twitter.
More puppies.
So I would like to pause on that map. This is our world community map. Those are all the contributors that have participated, not only as speakers, but also as poster presenters and the organizing committee. Quite impressive. Also, our first day has had almost 400 views on YouTube. And there are 205 views of the yesterday's presentation. So I would like to invite everyone to follow our Twitter channel, which is a cooperation of our institute of all the chairs. There's also a lot of content from other chairs, from the general psychology and also from the clinical psychology, for example, that helped to set the Corona helpline in Bavaria. And starting from autumn, there will be also some content from methodology, and it will be in English because the channel is in two languages. It's in English and German. And it, of course, shows a characteristic of our university and of our institute, because our university isn't a military academy, just as our dean Charlie Renner said, but we have something in common with the military. We really appreciate and we really live what is called a teamwork. And teamwork and coping as a team, this is what unites us in all the difficult times in human history and also now in this moment.
I think that that's a wonderful note to sort of end on, that this has been the product of teamwork. And I'd like to thank my wonderful co-organizers, Bahatung Cenk, Domna Banaku, Olga Lantukova and Yasemin Abra for their tireless efforts over the last 3 days, but also in the weeks running up to this event. I don't think it could have run any more smoothly than it has. Olga, maybe if you stop sharing, everybody will see your faces in slightly larger scale, so that we can all thank you for all your efforts. It's been a wonderful honor to listen to all our wonderful speakers, to be with you all over the last few days. We have truly enjoyed many of the talks. Some of them have been somewhat distressing, I have to admit, and I think that that's sometimes good too. We need to have a good, long, hard think about how to move forward together as a team, as a research community, and I hope that that work will continue in the various forms that we've discussed, whether it's our upcoming workshops, student competitions, or indeed continued exchange either on YouTube or on our whiteboard. I'm very, very, very grateful to everybody who's contributed so far, but your homework is to go and do more, to reach out across disciplines, to work together as a team, because we know that this is a global problem that needs not only global solutions, but solutions across disciplines. So one last thank you to you all. And I don't know if Baha or Domna need to say anything further on the topic. Sometimes silence is golden, but I know that I have wonderfully educated, wonderfully insightful colleagues. So now would be the time for any closing words. Yeah, go, Domna. You don't have to even raise your hand. We're not in a classroom.
No, I just very shortly wanted to say a very big thank you to you, Merle, and all your team for organizing this fascinating 3-day conference, and all the speakers. We covered a really wide range of topics. It's been amazing. We learned a lot. And I'm confident that this work will continue. We'll expand on this. It's not something temporary that we did due to this unfortunate situation. We have a lot to learn. and a lot more to do, which will hopefully help us take action on an individual level as a society, so that if we ever have to face anything similar again, us or future generations, we have learned something, we have taken something out of it, and we can combat it. And does not have to be another pandemic. It can be anything really. People mentioned climate change a lot these days. So it's been very inspiring and very fruitful. Thank you so much to everyone, and for giving me the opportunity to interact with all of you.
Thank you, Domina. And Baha, over to you.
Yeah, I'll just extend the thanks as well. And yeah, it's just been really good. I think we were hoping to really make use of the, make the best out of the worst situation, and use this opportunity to transform the way we do science, we talk about science. And I feel like the 3-day conference has really done a very good job in terms of achieving that. And I just want to finish by highlighting the 2 upcoming things that we were planning that will hopefully help materialize these ideas. One of them is, as Merle mentioned as well, the competition, the video competition for graduate students, which will, the submission will take place in September. So we here encourage everybody, all the students watching us and all the students of the lecturers watching us to submit their work there. And also we have a Frontiers special issue coming up, which will hopefully feature some of the work that has been presented here, but it doesn't have to stay just there. We have already been contacted by some of the previous presenters in the conference. Like the name suggests, the entire goal is to build bridges between disciplines, between geographical boundaries. And so it would be great if we start new collaborations, perhaps write new papers together. This could be opinion papers, this could be sharing data, like many of the talks mentioned before. So please do feel free to reach out to each other and to us as well, if we can facilitate that conversation.
Thank you, Baha. And yes, let's end on that. Let's talk about bridges and bridging various gaps. And without keeping you for any longer, I want to wish you all a very happy holiday. I wish you a very happy weekend. If holiday is still not in sight, please stay safe. And there are ways for us to stay strong. Thank you all. And I'm going to leave you with an image of just how far reaching our conference has been. Keep well all.